Our next speaker is Dr. Margaret Gedde. She's a Stanford-trained pathologist and award-winning researcher. Since 2009, she has focused on medical cannabis and helps patients with chronic pain, nausea, seizures, and other conditions get healthier, get off the pills, and improve their quality of life. Dr. Gedde is the founder of the Clinicians Institute for Cannabis Medicine and medical director of Vibrant Health Clinic. Her mission is to advance cannabis medicine through patient service, clinical research, and physician education and training. It's my pleasure to welcome Dr. Margaret Gedde.
Thank you. Okay. Thank you so very much. It's hard to express what an honor it is to be speaking on this platform because I have been specializing in cannabis medicine for just 5 years. And to be on the same platform as speakers such as Dr. Abrams and Dr. Mishula and Dr. Malka, again, is just an honor. They've been my models. So thank you, everyone. And this is the first time I'm giving this talk, so we'll try to make it smooth. So our problem that we're talking about is, of course, epilepsy today. As you all may know, there is an enormous unmet need for better treatments for epilepsy. We know that a seizure is uncontrolled electrical activity in the brain that is disabling in some way itself, and that also directly causes damage to neural tissues. The best treatments available to stop seizures include the anti-epileptic drugs, or AEDs, also include resective surgery and the ketogenic diet. And these treatments themselves are often disabling through their physical, cognitive, and behavioral side effects. So, despite the best, I'll go back a second, let's see. Despite the best treatments, about a third of epilepsy patients continue to have seizures and their consequences. So these are the patients termed treatment resistant. So what about cannabis? And I guess, yeah, there are a little bit of glitches in the slide. Sorry, the color isn't quite right. Maybe it was a version thing, but anyway. So we've been hearing, different references to seizures through the conference. We've heard that cannabis has been noted over the centuries to relieve seizures in some patients. Published clinical trials are small and limited. There are positive results from some animal studies showing anticonvulsant activity for both THC and CBD, cannabidiol, although there are some suggesting that THC can, perhaps in some circumstances, be a proconvulsant. Regarding toxicity, the most concerning side effect is, of course, the psychoactivity of THC. CBD does not have this side effect. So since seizures are something that can be observed, usually in a short time frame, depending on how many seizures the patient has, depending on the frequency, it would seem reasonable for a physician to suggest to a patient that it would be worth trying cannabis in some form to see if it could help to control their uncontrollable seizures. And indeed, seizures are a qualifying condition in Colorado for a medical marijuana recommendation. But I'd like to step back a bit and kind of, the formatting is really off on these slides, so I apologize. They looked a lot nicer when I did them. There may be reasons for a physician to say to a patient, sure, it's worth a clinical trial, a therapeutic trial, and let's see if this does help your seizures, but of course, it is federally prohibited. It's Schedule I. So for physicians who may want to recommend this to their seizure patients, we really find that we have to walk a very fine line. And I wanted to talk about this a little bit because there's been reference to this, and the federal prohibition lets us do certain things and not others. And the main thing to note is that there was a court case where a judge in 2002 upheld a permanent injunction against the DEA from pulling the DEA registration of physicians who recommend marijuana to their patients. And this was, it's very interesting to read. You can find it easily, of course, online. And it was determined that this is a free speech issue, that a physician must be able to give in their sincere medical judgment, a discussion of the use of cannabis, but even perhaps more importantly, the patients need to be able to hear this speech. So there are, of course, a long list of reasons why physicians such as yourself, such as me, might choose not to recommend marijuana. The lack of data that we've been talking about in different conditions, the stigma, the fact that your medical malpractice carrier might drop you, make you get a different policy, the fact that you can't get any insurance reimbursement from it, perhaps your institution takes federal funds, and all those things would be put at risk. But it's really not that your DEA will be pulled, and that's kind of a piece that kind of gets slept over sometimes. It is not then strictly illegal. I've heard it said, well, it's illegal to recommend marijuana. It's not federally legal. If it were, I would be violating a federal law. And according to the Colorado Board of Medicine that gives me my medical license, I must follow all state and federal laws. So if I were violating federal law by recommending cannabis, I would no longer have a medical license, and also the DEA would have pulled my registration. As we heard before, every physician in Colorado who does recommend cannabis must have a current DEA registration. So again, I have my registration. Nobody's ever gotten it pulled for recommending it, so that really isn't an issue, but all those other things are. I think I do need the water. Okay, so we are in this spot though, because we can't dispense. Goodness, so that would get us shut down and probably put in jail or something if we were giving cannabis to patients. We can't prescribe it, so we can't tell patients exactly what to get and have a system where they can go and get what we want them to have. We don't even know what they're using unless we ask them. So this again makes it very difficult, and it's very understandable why a lot of physicians wouldn't want to work under those circumstances. Okay. And then there's that other line, well, how far does the DEA let you go? Earlier this morning, I think it was Dr. Weiser said, gosh, why aren't clinicians involved in the dispensaries? The reason is that if you are involved, if you have a financial relationship with a dispensary, or if you're supporting their program, you have crossed the line, and you are now aiding and abetting, and you will get your DEA pulled. So again, we're stepped back from the dispensaries. Dispensaries, care providers refer to our practice. We inform patients about the different options available, but we have definitely this arm's length or more distance because of the federal law. And again, this is how we have sort of threaded that needle to be able to help patients in clinical practice without, having adverse consequences as physicians. Okay. So having said that, okay, there might be reasons to look at cannabis for seizures, but what about in children? I mean, they are clearly a vulnerable population. So again, looking back, now we're talking again, the talk's about treatment-resistant pediatric onset epilepsy. So if there's no treatment, which sometimes patients want to do, but they're actually discouraged from doing, the seizures are uncontrolled and you have the ongoing damage. So you have the risk of sudden death. So there's the acronym SUDEP, which refers to sudden unexpected death in epilepsy, and it's very real. So treatment is definitely encouraged with those treatments that I discussed, and sometimes good control, but we're talking about, again, the treatment-resistant population, so partial to poor control with a long list of adverse effects, no beneficial effects, and then there are certainly known toxicities, and then, of course, unknown toxicities because very few of these, I think perhaps none, have been specifically studied in children. So when we talk about not FDA approved, definitely medications and treatments being used in epilepsy for children have not been studied in children. So those risks are there. So what about cannabis or cannabinoid therapy? It might help some. The adverse effects are minor, stacked up against the others. And we have been hearing about this neuroprotective effect. So there is good laboratory evidence. I'm not sure of clinical evidence of neuroprotection. I'll refer to some of what parents tell me. But if you actually have a treatment that not only has minor adverse effects, might be efficacious, but then actually has a beneficial side effect, and again, this whole idea of side effects, some may actually be beneficial, with unknown risks, unknown long-term risks, and the short term certainly seems benign, then again, this is where each physician would then have to come down in that risk and balance profile for each patient that you're looking at and decide, would you recommend medical marijuana or medical cannabis? And I understand the idea of not using the term marijuana, but the program in Colorado is called the Medical Marijuana Program and Registry, and maybe we can just own it. Marijuana is cannabis, is hemp. It's the same species, so hey. So I'm going to use them both. Okay. So now the Epilepsy Foundation earlier this year did come out with a statement about medical marijuana, and they made the statement that if, in this consultative relationship, if a patient and their healthcare professionals, and of course with these children, with the families, feel that the potential benefits of medical marijuana for uncontrolled epilepsy outweigh the risks, then families should have that option. And at least to do a therapeutic trial, and then if it does seem efficacious, if they're seeing, again, the balance is positive, to continue that. Okay. All right. So now in this next section, I'm going to talk about what does that mean in clinical practice. So I want to give kind of some of the parameters we're working within and some of the lessons we've learned in clinical practice. And then in the section after that, I am going to present results of a retrospective data poll from the charts that I did try to do in as rigorous a fashion as possible from the clinical charts. So I do specialize in medical marijuana. I do that in 2 locations. One is at Vibrant Health Clinic in Colorado Springs, and the other we go out to the mountains and we see patients in Buena Vista. The first patient that we saw for pediatric seizures was in February 2012. And since then, especially with the CNN series called Weed 1 and 2, there certainly has been a very high level of interest in using, particularly the therapy, using high CBD and low THC cannabis extracts to control seizures. So this is continuing. It's definitely a thing that is still happening. Now, then, of course, with all the demand and with so many people who do have epilepsy uncontrolled, very quickly, the high CBD oil has been in short supply. So parents would come to Colorado, we'd see them in clinic, and then they can't get the oil that they came for. So we've had this branching out where parents would be going and trying all different things. And again, because we can't dispense or prescribe, they have to go out and get it on their own. And so they'll come back with all kinds of different things. And what I've committed to them is I will work with you on any type of cannabis you get as long as we can get some type of potency and composition information. If it's just homemade, we can try to estimate, but I always tell them we need to get a lab report because otherwise, it's really not medicine. I mean, I feel it's very important to know the doses. So, and then we do counsel about, the various treatments involved in clinic and provide ongoing follow-up through follow-up calls to assess then, positive and negative side effects, what dose are they using, what are they actually using, and how are the seizures changing, if they are. Okay. Oh dear. So, gosh, is there any way this worked on Monday when we had the slides? There's a whole figure there. I don't know what the difference is from Monday. Is it a different version of Office being used? Well, that's the second one. So I did have a bar chart just showing you that. We're seeing between 4 to 6 families per week in clinic, and I would say about 2/3 of them are from out of state, and 2/3 are from in Colorado. And I showed you a year's worth of data, or just the numbers there, to show you that they're coming at a high rate and it's not stopping. This shows you the states that they're from. So from virtually every state, one from Canada, one from Mexico. So again, a great deal of interest, and we've had to kind of control the flow. We'd see more patients per week if we could handle them. So, okay. So again, the issues. Doctors can't dispense, so the patients and families must locate and acquire the appropriate products. We have no control over what patients use. I rely on the patients and the families to tell me what they're using and how much. The doses are little known or unknown. Optimal dosing schedules are unknown. I did want to make a point in here somewhere that, my original training is in pathology and research. I was in the lab for 12 years. I worked in the pharmaceutical industry for 4 years and became a clinical doc just 11 years ago. So I have kind of a varied career. And when I started my clinical practice, I didn't know anything about cannabis as a medicine. I was looking at nutritional support and hormone balancing and really, again, that kind of holistic approach to helping patients improve their health. So I'm not a pediatrician. I'm not a neurologist. So some would say, well, you're practicing outside your area of specialty. And by that, I am. But my specialty at this point is medical cannabis. Because who is going to see these patients and advise them if it's not the doctors who are doing it all the time? Because doctors who aren't doing it, you don't know about dose. In 5 years, I've had a chance to build up that information. So again, I stand here before you saying it may be bold or brazen, But that's what we're doing, and we're seeing the kids and working with them and learning how to use the, the cannabis medicines for their ailments. Okay, so our clinical process is, we see them in clinic, we do baseline data collection, get the documentation of their diagnosis, get the, the history of physical, what other drugs are they on, and so forth, the course of their treatment. We talk about the different cannabis products, help them. They're like, well, where do we get this? They have a lot of questions. On the follow-ups, then we go back and just, again, talk about the seizures and what other things they're on and the things they're seeing, and just try to guide them with what we're learning. And we have learned, I've changed the advice I give to patients over the approximately year that I've been doing these close consultations. But an important point is that, again, I don't replace the pediatrician or the neurologist. I'm a specialist on their team. We are getting, actually, at this point, direct referrals from some doctors. They say, go see Dr. Gedde. She's going to help you to get this treatment working. And I always tell them, please go back, go to your neurologist, get your EEG follow-up done, talk to them about the drugs they're prescribing. I never tell somebody, change this or change that. Now, parents often do it on their own if they feel comfortable. But again, I want them to continue those relationships, certainly. Okay, so advantages of working with this population is the parents are so highly motivated. They often have extensive support, so these online Facebook groups and other groups, so they have a lot of information already coming in, and so the doctor does have to be a bit flexible to work with that, and they may have support in acquiring the appropriate products and getting them tested, even though that has become more difficult in Colorado in the past year as well. Okay. These are then some of the products that have been used by pediatric patients. So again, what parents have come back and said we have obtained. And this is focusing on these high ratio, I'll call them high ratio CBD to THC products. And high ratio in this context, I'm referring to about 15 to 35. That range of CBD to THC seems to be what we could call a high CBD product, where there is no psychoactivity of the THC. We can't really distinguish that they're taking THC. Locally grown strains. So again, this is the slide where I refer to brand names. So Charlotte's Web, certainly that has been the largest the largest group of the patients have been using Charlotte's Web. There's another strain called Haley's Hope that a number of the patients have been using in Colorado. R4 is around, something called Ballantine, and then Unknown. Parents come in and they say it was high CBD, and so. And these are usually, cannabis oil extracted and then infused into an oil base, and they are swallowed, so they're getting the persisting, long-lasting effect of the ingestion, where it's processed through the liver. You've heard about the 11-hydroxy conversion, and that does work. Some parents then are turning to these imported hemp tinctures. These are actually sold on Amazon now. Technically, they're illegal, but I guess the Amazon lawyers figure it's okay. So they can get Bluebird Botanicals or Cibidex or the Dixie Dewdrops, and there's certainly mixed issues about these. There's questions about how clean they are, if they have pesticides or heavy metals in them. But I can say that some families have gotten actually seizure control using these products. So I tell them I'll work with whatever you come with as long as I have some sort of dose information. And then we've been hearing about the transdermal patches by Mary's Medicinals, and those have been effective too. So you can get the long-lasting effect through the skin. Okay, so that's the range of things. All right, so this is just a slide to show you what this looks like. We had Heather Desprez, from Can Labs yesterday, showed us some profiles. So this is, again, that pie chart shows us the cannabinoid profile. And the light blue is CBD, and then those other slices are other cannabinoids. The light green is THC. So this is just to show you, locally grown strain example 1, on one side, locally grown strain example 2 on the other. They're very similar. They're not identical, but they're very similar. No doubt the terpenes and so forth vary. The one in the middle is one of those ones you can buy online, imported hemp. So really, they're all very similar in composition, which is helpful to know. But I chose these reports to show they were examples that all had about that same 30-to-1 ratio. But then we do find that the same strain will vary in the ratio, all the way up to like 50-to-1, where some parents say, this isn't working now, I need to add THC, the ratio's off. Or if the ratio's too high, then that may not work as well either. So again, we're always dealing with this issue of the plants varying a lot. Okay, now since high CBD strains haven't been available, I don't know if any of you have heard that THCA, the one that is non-psychoactive, sort of raw THC, it actually can help control seizures. And I sort of couldn't believe it. I was like, wow, that's amazing. How does it do that when I first heard it? Apparently this was pioneered over in Australia, again by parent and advocate groups who they didn't have high CBD strains, so they said let's use raw THC, and found that that did control seizures in their treatment-resistant epilepsy children patients. So they've been using it for at least a year or two, I think, before we started using it, I guess in Colorado here earlier this year. It is a little tricky because it's less stable. So there are issues, again, about product consistency and stability. Okay, but it's very available, right? Because it's in all the THC strains. So in theory, a parent could just get regular marijuana, but always get it tested. You know, they could prepare the oil and then get it tested and actually have a medicine for their child to use to control seizures. So again, it's kind of out there for a lot of us, but okay. So a couple of patterns I want to explain again that we're seeing in clinical practice, and then I'll go to the study and the data. So time to steady state. It's not simple pharmacokinetics. It goes into multiple compartments, and as we know, cannabinoids are cleared out of the body slowly. So when somebody clears slowly, the time to steady state is also slow. So if a patient tries a certain dose level based on milligram per pound of body weight, and they're on it a week and they didn't really see the seizure control they want, and they go up, then they go up another week, well, it actually seems to take about 3 weeks. Yeah, the text is off the bottom of the slide, but I remember what it said. So it takes about 3 weeks to reach clinical steady state. I'm saying clinical steady state. I don't base that on published numbers. But it seems that if they stay on a given dose for about 3 weeks, that's enough time to see the evolution of the dose building up. They may see response in the 3rd week they didn't see at first. So I counseled them, if you go up more quickly, you can get ahead of yourself and then be up in a zone where you're having problems. And then the second thing, which very much relates to this, is the same thing we've been hearing from others about this kind of bell curve or biphasic response, where unlike many medications where you go up and then after a while you don't get any better response, you just get more side effects, but it doesn't reverse. You still get the control you had. For cannabinoids, we see this where it doesn't work as well. So they might actually, again, if you can imagine the scenario where they go up kind of quickly, and they're still not having their seizures controlled, and they say, what do I do? Do I go up again? And I've been telling them for a while now, no, what you need to do is go down, because they actually got over to that other side of the curve without knowing it. So again, I tell them, you're over here. We need to back up so we can be here. We need to adjust it around here. And so again, we're talking about less good seizure control along with then side effects that we can talk about. Okay. There was a whole thing on the side about the receptors. So CBD seems to bind to multiple receptors in the body, and that could explain, perhaps this biphasic response where at a lower dose you're hitting the high affinity receptors, and then as you go higher and higher, you're starting to hit low affinity receptors and adding in effects, and that would give you kind of this bell curve type response. Okay, so that's kind of the context that we're working in clinic with. Okay, now this is the section about the study. I had all these clinical charts and all these patients that I've seen and done follow-up with, so I, designed this as a retrospective cohort. I didn't want to just, pick ones that I knew best. I went back into all my charts and to look for all the patients who met the criteria of treatment-resistant pediatric onset epilepsy. And in that time frame, we have more since then, but they didn't have enough follow-up, February 2012 through March 2014. And that was a group of 187, so a solid enough number. 6 of them I did report on previously in an abstract I'll refer to a little bit later. So all of, these are mostly new patients, haven't been reported on. Okay, the efficacy endpoint was % seizure reduction during treatment in a 4-week period relative to baseline. And this is the FDA recommended endpoint or close to it. When you do a prospective study, you have all your data collection instruments and you can give all the instructions and be real careful. This was not that clean. This was messy clinical data, going back to the charts and trying to pull out the information. But that's how we did it and based it on numbers. I always made sure I got seizure numbers. And I did 2 time points. So 4 months is a pretty reasonable trial to, even with kind of making clinical adjustments, we're always adjusting and trying to customize. So again, there's no set protocol. It was, in clinical practice. So after about 4 months, that was a good time period to say, okay, where are they? So I pulled up, an assessment from the first 4 months of treatment, the latest one I had. If I had one at 3 months and not 4 months, I took the 3-month one. Some patients had only been on it for 4 weeks. that was my cutoff. They had to be on it at least 4 weeks to make it into the data. And then I also wanted to look at their very most recent assessment because the patient who's been on it the longest has been on it for more than 2 years. So that would look at the question, is this sustainable? Is it something that just falls apart after 4 months? So every outcome slide I show you will be that kind of that 4-month window, somewhere in that 4 months, and then the most recent one, which varies. And then, of course, we looked at the other medications and adverse and beneficial side effects. Okay, and then at this point, I will say that, this really was almost virtually done by me. I've had some collaboration from another physician in our clinic, Dr. Kirk Anderson, and some assistants, but this was me doing the follow-ups, and it was self-funded. So it was, me working with the patients. Again, financial disclosures, I have no financial relationship with any provider. Again, we have to keep that distance. So I haven't, been able to collaborate in that way with providers. And so this is kind of pretty much all me. So if the errors are mine. Okay, all right. So this was to kind of just list, I tried to list every different limitation I could think of for an observational study, and there are many, and I think about half of them are cut off. It's clinical practice, it varies, the data collection wasn't real rigorous. It's all patient, parent reported. There were different changes, like some kids had surgery in the middle of their treatment course, medications changed, all those sorts of things you can imagine. But then an advantage is that, we've got the clinical record. Let's find out what we're seeing, and it is real clinical experience. So this is what's really happening with the patients. Okay, and then we can learn, what are the best ways to help them. Okay, so then, just to take a moment to refer to 2 abstracts that had come out, and one, actually the top one, was published in Epilepsy Behavior in 2013, studies that do report again on this population of children using this type of high CBD, low THC oil. So the top one, parents were self-selected to participate in a survey from a call put out by an investigator on a Facebook group. So again, they were the ones who said, yep, I used it for my child, and this is what happened. The bottom one is one that I did with my collaborator, Ed Ma, and that one we presented at the American Epilepsy Society meeting a year ago in December, and that one was actually, the patients were actually selected by the provider of the extract. So those were more kind of selected. Those were ones that had a particularly good outcome. You can't see the results on the bottom. If we can just look at that 100% seizure reduction, 11% they saw, so that's the seizure-free, and that's kind of a good benchmark to look at. 11% in the top one. In that selected population, we actually had 45%, 100% seizure reduction. So again, that was a selected population. As we go forward, so if we talk about responders and non-responders, it's working versus it's not working, the 50% seizure reduction mark is a good one to look at, and I'll point that out in the slides that I'm going to show you in the data. Okay, but then, oh boy. Okay, so, all right, so we started with 187, entire cohort. Started cannabinoid dosing. A lot of them are still waiting for the oil. So 43 hadn't started anything. They said, we went home, we're going home to Ohio, we'll be back in the fall. 20 we couldn't get in touch with, we don't know. Did they start it, did they not start it? We didn't have an agreement with them that they would follow up. So 123 we did have information on, they had started dosing. The assessments that I wanted to be complete, let's see, less than 4 weeks or missing data as best I could. I just couldn't pull, I couldn't get the points out of the clinical chart. So 16 had to drop out. So I am going to show you data on 107 of these children or adults. They were actually from a half a year old, 6 months, all the way up to a 45-year-old man who did have seizures start when he was a child. And the average was about 10 years old, or is about 10 years old, 57% of the entire cohort. Okay. Okay, and then again, just the information that we would collect. We've gone through that. We try to collect the dose information. That's one of the trickiest things because we had to calculate and use our chemistry and adjust for density of oil and those sorts of things. Okay, and that was the primary endpoint. I already referred to that. We're talking about change in seizure frequency, so we assess numbers, again, with the same type of seizure. Some patients have thousands, some have 20 in a month. So, collect the same type of data and look at the percent change relative to baseline. What types of epilepsy were we seeing? So pretty good representation there. Unknown, about a third, and that's pretty consistent. So, a lot of cases you just never know why they're having seizures. With the genetic testing, we did have, 36%. Structural is where there is some kind of developmental malformation of the brain that you can see on an MRI, and then secondary is where something happened, and they had seizures after that. Just running through that, some of you know these genes and are interested in them, Dravet syndrome, we had a good number. We have 16 Dravet kids. CDKL5 is one that's out there, the Rett syndrome gene. So again, pretty well represented. I'm going to refer to the storage diseases again. There were 4 kids who had storage diseases, which are pretty severe. Okay, structural causes, cortical dysplasia, cortical band heterotopia, microcephaly, macrocephaly, schizencephaly, a couple others under there. Hypoxia, trauma, infection, stroke, toxic exposure. We had all of those represented, so very broad selection of kids with epilepsy. Okay, so that's what their disease was coming in. What were they using? Because it wasn't just one thing. So all the blue are these, what I'm calling the high ratio CBD to THC. The other third, so that was 2/3. The other third was different slices. So the THCA is right here. THCA plus, so we found that combining them often gave better results. So if a child wasn't getting the best results with either THCA or the high CBD, we had the option to combine them. This is where you come back to that entourage effect. We're definitely seeing that combinations, in many cases, work better than the purified compound. So all of, none of this is purified. It's grown in cannabis. It has presumably some level of the terpenes. And then what I'm calling the low ratio CBD to THC. This was usually where they started with a high CBD oil and then said it's not working as well as we want. We're going to add some THC in and change the ratio and see what happens. Parents tell me for their kid, some parents, they say it works better when we add the THC, and we got it down to a 5-to-1, even a 1-to-1. They'll tell you their kids are not impaired. They're not high, but it works best to control the seizures. So a whole range, and again, this is what's kind of happening out there among the kids that maybe you're seeing in practice, if you're seeing some of them. Okay, so this is a core results slide, and I'm going to spend a little bit of time just to be sure everything's clear. So, and I guess I'm okay on time. All right, so I took that quantitative data. I got a % seizure reduction for each one, but again, the data's messy, so I'm not going to put real, hard numbers on it. I divided that into 2 groups. So if they had the same number of seizures, if they had anywhere from a 25% reduction to a 25% increase, we're just going to call that the same. If they had more than a 25% increase, that was increased, so they did worse. Some fewer, that's if they had between 25% and 50%, so that's your yellow. Now, a lot fewer, 50% to 80%, and this is where we start to call them responders, okay? So if they're green, blue, or purple, they were above that 50% mark in these assessments. Greatly reduced is between 50 and 80%, 80 and, 50, what did I do? A lot fewer. 50 to 80, greatly reduces 80 to, 99.9, up to gone. So gone is the seizure-free condition, 100% reduction. Okay, now, first assessment is here. Again, now all the slides are going to have that first 4 months and then the most recent. Looking at that, I say, well, maybe there's a little bit less efficacy in the most recent one. When you do a chi-square analysis, it's not significant. Of course, things were changing during this time. One of the things that changed is parents are so motivated to get their kids off of those AEDs, the anti-epileptic drugs, with their pretty severe side effects. So the average, well, I'll tell you that when they started, 7 were taking no drugs, and it was between 0 to 5. A couple kids actually had 5 drugs on board. And many reduced their meds but didn't get completely off of one. So when I counted them, actually the number that changed, if they actually got completely off of one, then there was a change. So for everybody, there was a reduction of, like half a drug, which is not a real thing, but, and then reducing a lot of the others. And then again, okay, so the first assessment was 4 to 16 weeks, anywhere in there, and then the most recent was 4 up to 118 weeks, so quite a range. But again, I wanted to be able to show what happens over time. So, they're pretty similar, and again, keep your eye on the green to purple, because again, by FDA standards, that's considered a responder. And it is, again, relative to baseline. Okay, so that's all analyzable patients, the 107. Wow, so is it different? Does it work better for some conditions than others? And this basically shows that really no, it doesn't. So, okay, genetic etiology, they reduced their AEDs, kind of the same pattern here. Those are the highest numbers, structural, secondary. You know, they're all kind of the same. There's no difference by analysis. These numbers are too low to really get anywhere with it. But they all of the groups did reduce their drugs. Yes. Okay. I'll focus in on just a couple. So there are 2 disorders that are called orphan disorders. So there's interest in finding treatments for them. So Dravet syndrome, again, we have, you know, a significant number of responders, both initially and at the latest ones, the latest assessment, and then Lennox-Gastaut is another. Only 7 patients there, so it's hard to say, you know, does that mean there were none seizure-free, or, you know, would it have been different if we had greater numbers? So again, we really can't tell if there's a difference. Maybe the Lennox-Gastaut kids do a little bit worse, harder to treat. But they were the ones who got off of, I don't think the number's there, but they got off of more of the drugs than the other kids. Parents were really motivated to just get rid of them because they weren't really helping. This group, I did split out storage disorders, only 4 kids. As you know, their storage disorders are when the cells, you know, can't take out the trash essentially, and cells get poisoned, including the nervous system, and they're usually fatal in childhood. And all of the 4 got really good results, and even one moved from, you know, great seizure control to complete control to become seizure-free. So, you know, I don't know what that would look like if we had more, but that was really encouraging, certainly for those families, because, you know, these are all treatment resistant. Again, they've been through many, many treatments and haven't succeeded in getting control of the seizures. Okay. All right, so that was all of the types of cannabinoids. So let's break it out again another way. Let's slice it another way. Same thing. Interestingly, again, more THC, low ratio, anywhere from 1:1 to just like 5 to 10:1 CBD. They also are getting some good responses. Hard to say if it, you know, better or worse than the others. THCA alone, as we work with it clinically, so we had to work out the doses. So again, this is the optimized result. And again there, so the THCA together with the CBD, they did that, combined it because their kids weren't doing as well as they wanted. So that's the result we got by the combination. Okay. And then just focusing on those high ratio CBD to THC kids, because that was the largest in the cohort, 74 out of the 107. Again, it looks the same, looks, you know, looks like a lot of responders there. And then just again, because it was Charlotte's Web, that was the largest group, I split those out. So 59 of the 107 were on that particular oil alone. And again, that looks the same. So we're seeing, you know, it works for some and it doesn't work for others. And I can't tell you what the difference is at this point. Okay. Adverse effects. All right. At therapeutic doses, sleepiness, and maybe they seem to be able to get used to it, and some increased drooling, so sialorrhea, which a lot of kids have to watch for because they're aspiration issues. So it's important to tell parents about that. If they're above the optimal doses, up on that other side of the bell curve, excessive sleepiness, and all of these, if there's too much cannabinoid, I tell them right up front, you can have more seizures. So you can use a dose that's going to cause more seizures, or different types of seizures. So that's very important. Again, parents might think, well, if this much is good, more is better, and it's not. So that's a big part of our counseling. So if kids go in, you know, to an emergency room where the cannabis seems to be causing more seizures, it may well be, and it's because the dose is wrong. And we've been hearing that again and again in the conference too, how important the dose is. So, you know, knowing what to do with the dose is a key part here. And then there are other things like poor appetite. They'll kind of be irritable. They just won't seem like they're really comfortable at the higher doses. THCA, this is kind of new. So at therapeutic doses, no side effect noted by the parents. Above optimal doses, excessive sleepiness, and again, increased seizures or new seizure types. So important to know where you are on that bell curve. Okay, what about beneficial side effects? Let's call them that. This was a long list, so I'm going to have to remember them because they've fallen off the bottom. So improved cognition and interactions. Parents talk about it. They're more alert. He called me mom. Hasn't happened. Kind of big. Parents notice that. Better sleep, better appetite, better gut function. So many are chronically constipated. Now they're moving their bowels spontaneously. It's huge. Improved immune resistance. They don't end up getting terribly sick with pneumonia and increased seizures in status in the ICU like they did. not all the kids have this result, but parents have noted that. Other things, improved behavior, calmer, easier to manage, more alert, sharper. I think that was the last one there. Okay, with the THCA, they talk about alertness and, interestingly, language. The THCA, my child was trying to talk. I haven't seen that. So improved language, alertness, cognition. Okay, and then again, to just kind of give a little bit more information about the change in the other drugs. I mentioned, okay, there was 0 to 5 when they started. The number who were on no other medications, and including the ketogenic diet, which I didn't mention, I'm including that, went from 7 to 14. So 7 got completely off, and some added more. So a few had increased them, and those, of course, would probably be the ones who did worse. It really wasn't working. And then, a number reduced by 4. The median was 0. Kind of most, I guess you could say, stayed the same, but they were reducing the dose. I didn't go back and pull that as for the percent of that were reducing, but a lot of them were average of minus 0.47. This isn't significant, but just showing that all the treatment groups actually had reduced medications. So if over time they weren't getting better and better seizure control, keep in mind that they had been weaning off drugs and they were, on fewer. So let's see, I wanted to be sure to mention something else about the side effects. Okay. Negative side effects. So if you add cannabis on top of another anti-epileptic drug, and now based on the interactions in the liver that Dr. Lauren Borgelt laid out for us so beautifully, maybe you've pushed up the concentration of clobazam in the blood, and now the child's extra sedated or they're having toxicity. So that's an adverse effect, you could say. It's the combination. Now, of course, the thing to do there is to pull back down on the other drug, but that's, again, where parents and kids can get into trouble. And then when we talk about beneficial side effects, that, again, would be the ability to reduce those. So you're reducing the adverse side effects. So it can go both ways with those interactions. That's a very important area where we have to be real careful. Okay, then let's talk a little bit about doses. Again, this was observational. I just collected the numbers as far as what was working, what was their best, what dose gave their best result at that first assessment in the first 4 months. And the thing we can see is that the THCA is a lot lower. It's like little tiny amounts. Some kids, it's like 2 to 4 milligrams a day is the dose, and more causes problems. The high ratio CBD to THC is the highest, but there's quite a variation, a range. Parents often might have gone up to 4 or 5 and then come back down. So that's just to give you a sense of where those doses are. Again, in a milligram per day and then milligram per pound, average and standard deviation of those groups. Okay, so then this is just the summary then of this cohort. And this was at the first assessment. So again, looking at this, if we can consider a responder, anyone with more than 50% seizure control, we did see 71% with 11% seizure-free. And so that's what we're seeing. That answers the question, what are you seeing, Dr. Gedde? So, okay. So some responded well, some didn't. About 10% did worse, about 10% seizure-free. All groups reduced other drugs, but had the same seizure control. Lower doses often gave better control, and all 4 cannabinoid combinations were potentially effective. Okay, now we've heard, certainly stories from other doctors, perhaps more on your side of things, because again, this is this divide between doctors recommending and those who don't. It's just kind of how it is. So kids go into the emergency room, toxic from a combination, or they're having more seizures because the dose isn't right, or just because they're sick. So I think it would be great to be able to capture some of what those emergency departments are seeing, and I think that a case control study would be great, where you look at kids coming in on cannabinoids, because I'll hear things, the cannabis doesn't work, it's making kids worse, you should stop it. Parents are advised that. So, maybe match them to controls for other kids coming in, and that would be great data to see and try to understand more what's being seen, in other places. And then I did want to, of course, mention the GW Pharmaceuticals Epidiolex open label study. They released data on that in June. So this is all from their press release. I don't have any other inside information at all. So this is just from what they've published. Now, of course, Epidiolex is purified cannabidiol, CBD. I hear, but they didn't mention that the doses can go quite high. So this might be an example where a purified compound takes more to be effective than if you've got it combined with other things. I've heard that kids can be on hundreds of milligrams per day, and they wanted to even increase it further. But again, that was scuttlebutt. So this was an open label study, not controlled. It's an observational, physician-led. That was their efficacy endpoint. The FDA recommended one. They did 12 weeks of treatment, and they had 27 patients, and they did get that 15% seizure-free. So interestingly, we again have this slice. It doesn't work for everybody. About half of their patients got to that kind of responder level. So it was interesting. Again, purified CBD. Okay, so what I would like to do next is to do a prospective study, because that's a lot easier than trying to go back through clinical charts. And the state, has issued a request for proposals. So I'm going to be right in there and try to get funding, not only to enroll them prospectively and make sure all the instructions are there, but then to fund that independent testing. Because again, I'm relying on the reports they get from providers. So I think that's just critical. That's one of the things we've talked about, to know what's in it. And then if we can help them buy their cannabis products too, I don't see why the state couldn't do that. I mean, the federal government won't, but that would be a good way to enroll people. So I'll be working on that to, kind of refine this information. And then I had kind of a vision of cannabis in the future. And of course, this is after the federal prohibition is lifted. I would love to have compounding pharmacies that we can get, say, a purified CBD, purified THC, purified THCA, terpene, composites, and then we can combine them, and then we could order the customized ratios and work with it, and we'd have those specialized pharmacists. So I think that's where we could go. We could honor the the benefit of combinations while still getting accurate potency and quality information. Okay, final summary, retrospective cohort. We've gotten outcomes from a dynamic clinical process, and generally we saw a lot of positive results in a lot of the kids, especially if they were able to get off the other medications. And this is just thanks to my coworkers and staff at Vibrant Health Clinic and at Gedde Whole Health, and just saying that we could use help with the kids. If anybody's interested in collaborating, or we're open. If anybody wants to kind of participate in doing what we're doing, we need qualified physicians who are interested in doing this work. So it might not be any of you, but you might know of somebody. So thank you very much.
We will be taking some questions. We have a little extra time today. We're going to start right here.
Thank you for your work in going back and getting this data and presenting to us. I'm Dustin Sulak. I'm about a year behind you, 40 pediatric patients in Maine right now. And I'm wondering, just from your observations, about a couple trends that I may be seeing or that parents are reporting, if you could comment on. One is Keppra making the CBD less effective. Do you see any of that? Also, you mentioned the clobazam levels increasing. I'm wondering if any of the other AEDs you've seen increased blood levels and having to decrease the dosage. And then my last question is, why milligrams per pound? I'm seeing this a lot on the internet. Everything else we do is milligrams per kilogram.
Oh, right. Well, the last one is just, that's how Americans weigh themselves, really. So I didn't convert. I could go back and convert everything. Parents often will look at their bottle of oil and they'll kind of calculate themselves what's 2 milligrams per pound, and then they'll tell me I'm giving 2 milligrams per pound. So it is a flaw, actually, and it would have to be converted to be published, I think. So as far as the drug interactions, I hear a lot of different things from parents. I haven't personally gotten the levels. So again, they go to their neurologist to get the drug levels. Sometimes I see them, sometimes I don't. I hear stories more than I see the results. That's kind of how it's been so far. Keppra, yes, an interaction where, and Depakote, valproic acid is the other one, where they say, well, if they have that medication, the CBD doesn't work as well, and that may be where, I'm not sure if, and Dr. Borgelt might be able to tell us, because I don't have this all straight yet myself, but if those drugs are inducing the metabolism of CBD, then you're going to have a lower effective level of the CBD. And so they may, or, there could just be interactions in the gut. There could be binding in the gut where it's not getting absorbed. Or I suppose there could be interactions at the receptor. So I think there are probably 3 different levels, just simply getting absorbed, the changed metabolism, and then, interactions at the receptor, which I don't know that there are any.
Great, thank you. And I wanted to confirm the ultra-low dosing of THCA is something I've seen effective in my practice. And the Epidiolex trial, I found a letter to investors on the internet their dosing range is 2.5 to 25 milligrams per kilogram
Yeah.
of body weight per day, which is way higher than the
It's like
data
1
that
to
you-
10 milligram per pound, exactly exactly. So, it's so much more, and then there's more potential for toxicity, it seems to me. So if you can get the total dose burden, I guess, load down with the combination, then that seems like a good direction for me. But
Thank you.
yeah, excellent point.
A lot of these kids with epilepsy have also other neuropsychiatric conditions diagnosed. Some of the diagnoses are actually even correct. And many of them have symptoms that are neuropsychiatric symptoms. Do you have anything to say, or do you have a plan or a thought about collecting data on, besides seizure activity, the other sorts of things that these kind of seizure kids and the genetic mutant kids have, the unfortunate combinatorial problems?
Right, yes, and I didn't mention that actually a fairly large percent of the children in this study do have autism, or autistic spectrum, so that's a very common thing. And so that's something I could have pulled out and talked about how their behavior was better and a lot of benefits for those kids. Autism is not a qualifying condition in Colorado. Sometimes parents come and say, my child has seizures, but really why I'm here is for the behaviors. So yeah, that is a whole area, and I think if we can set things up to capture the data, then, then we'll be able to analyze it later. Absolutely, thank you. Oh, sorry?
Over here.
Oh, good, thank you.
Hey, Margaret, Regina Nelson. We need to talk.
Oh,
I have
good,
a question,
thank you.
kind of coming back to Dustin's question, because I hear a lot of things from parents, and we're dealing with a number of pediatric patients right now, but when I was also at the International Cannabinoid Research Society, I spoke with some parents from other states and other people as well and talked to the researchers there, because one of the things that I've heard from many of the parents is about carbamazepine, because carbamazepine signals through the CB1. What it does is it closes down the CB1 receptors.
Okay.
And then when a child is given CBD oil after, and it opens up those receptors, it's the carbamazepine that then poisons their liver. And that they actually had a fatality like that at Portland, in Portland, Oregon, at the Children's Hospital. And that's how they had learned about this. Yet, as I'm bringing it up, most people will bring their child off carbamazepine before starting them on cannabis oil.
Right.
But I'm finding some adults with long-term seizure disorder are on it, and they've been long-term cannabis users. Is it that difference between using a THC-based cannabis oil probably and a CBD-based in that triggering? Or have you heard anything about carbamazepine? Maybe
I
that's
actually
better my
didn't.
question.
And this is, again, an area where, again, not being, say, a neurologist grounded in the drugs, I do come into it kind of naive, and we're watching the clinical pattern. So I can say that a number of the patients in this study are on Tegretol carbamazepine. I'm just thinking of one in particular who, Lennox Gusteau, hasn't done really that well, had some seizure improvement, but is still on the drug. So I actually don't know if that's a consideration for that child. So no, I hadn't heard about that. And probably, getting clear on all these interactions. The main strategy for a lot of parents has just been, let's try to get them off it. But you have to be very careful with that too. The signaling issue. Thank you. So yes, this is what's going to really help inform what gets them, better results. Okay. Yes.
Hello. I have a patient at our dispensary currently, 8-year-old who turns 9 today, and according to the text message I got from his mother, will be his first seizure-free birthday in 8 years. He has Lennox-Gastaut syndrome, and her main question for me to ask here at this conference was opinions about IQ in the developing brain of children and relations to cannabis therapies, and what your opinion is on that.
Well, when in a patient such as that with the Lennox-Gastaut and other kids with seizures, so what you're already dealing with is the encephalopathy from the seizures. So Lennox-Gastaut is specifically it's progressed into this sort of more advanced encephalopathy. So I think it probably will be difficult to kind of tease out the effect of the seizures. If you can eliminate the drugs, then at least you're not looking at that. But the effect of the seizures and that, static encephalopathy already there versus what might be long-term effects. I mean, I think we need to assume, from studies we do have, we know that certainly THC affects the developing brain, and the advice is, really nobody perhaps should use THC at all. if it's, not for a very, a compelling medical reason up to age 25. That would probably be the best for development. So in a child like that, it's fair to say we don't know, because how could you separate that? And that's where we really do want those. We need randomized controlled studies, right? I would be proposing to do that right away, except you'd have to use NIDA marijuana, and there's no way to do those studies. It's not the same. So really don't know. There is that risk there. So it has to be weighed. Is the benefit of the cannabis in controlling the seizures, better than that risk? And certainly, if that child could, perhaps over time, taper off the cannabis, then that would probably be the best outcome. And Dr. Meshulam had talked about how CBD seems to have epigenetic effects, where you get this, we've heard this from parents as well, where it seems like the longer they're on it, even if the seizure control isn't all that great at the beginning, that the longer they're on it, kind of the better they do. So there may be a cumulative process of, quote, healing, but so eventually if he could get off of that, then, that would be the most conservative approach. But if then the seizures are occurring, it's going to be better to control them, I would imagine. Does that answer the question?
It does. And to let you know that in the 4 weeks that he's been doing CBD, he was doing a 1-to-1. It didn't work. We moved to a 1-to-3. Significant improvement. And then with the addition of THC, he has become seizure-free and has weaned off everything else. So it's been a pretty magnificent experience.
4 weeks.
Yeah.
Yeah, it can be, and a lot of kids get that. Yeah,
we have time for one more question, one more quick question.
I'd just like to say thank you again for everything that you're doing with CBDs and kids. I make actually a medicated pixie stick, which is high in CBD. It's actually 2-to-1 THC to CBD. But we consider our CBD, and CBN. And we work a lot with CBN through our decarboxylation process. Have you looked into the coalition between CBD and CBN? Because we've found, especially with seizure disorders, about an 80% success rate when they have both CBD and CBN and THC all together. And I was wondering if you've looked into that at all and have seen the difference between CBD and CBN, because we found the CBN itself is very concentrated on seizures specifically.
In this cohort, no, there was one child that was using a CBN patch for sleep, but really not significant dosing. I had heard that. I'd heard, that CBN was reported to help control seizures. So I think that's another piece. I think it's great to have, all these different tools. And that's what I tell the parents. We're going to start on this or whatever you have available, and then we can add other things in and try to optimize. So knowing that CBN could be another thing we can vary and combine, I think is very, promising then. It gives us just a little bit of hope that we can, continue to improve the outcomes for some of these kids who aren't doing as well. Okay. Well, thank you so very much. Appreciate it.